Last time we discussed the acute arterial insufficiency of the lower limb. Now we will discuss the cause and the symptoms and the management of chronic arterial insufficiency of the lower limb. The most important cause of chronic arterial insufficiency of the lower limb is atherosclerosis. 20% of the people after the age of 70 develop chronic peripheral arterial disease, mostly lower limb as compared to upper limb. The symptomatology of the chronic arterial insufficiency is the intermittent claudication. Claudication means the patient complains of dull ache in the muscles of the lower extremity depending upon the level of occlusion on walking for a but certain distance. The distance which he walks without pain and the point where the pain starts in the muscles is called claudication distance, and this claudication distance is variable depending upon the degree of the occlusion of the arterial system. The claudication distance is variable, but the pain goes away when you stop walking. Within 1 to 2 minutes or 2 to 3 minutes, the pain goes away. This classical pain, dull ache in the calf or it is very diagnostic of vascular claudication. The pain which goes away on rest or stopping the exercise within a couple of minutes, this claudication is called vascular claudication. The underlying cause is vascular occlusion. The second type of claudication is called spinal claudication, which is a result of spinal stenosis. The nerves, they are compressed, maybe as a result of osteophytes or disc prolapse. The pain is burning in character and is distributed along the dermatome. If the distribution of the pain is dermatomal, then it's most likely the cause of this claudication is spinal stenosis, which is called spinal claudication. This pain never goes away with rest, versus vascular claudication, the pain goes away with the rest. This intermittent claudication is a feature of vascular claudications in a patient who has got a chronic arterial insufficiency of the lower extremity. These intermittent claudications can proceed to the rest pain. The patient has got pain all the time in the calf muscles or in the foot. And this rest pain, if is not checked, further leads to development of ischemic ulcers that is present in the distal part of the foot on the toes. And these ulcers, they are deep, very painful, occurs in the distal part, and poor granulation tissue. And if it is unchecked, may lead to development of tissue loss, that is gangrene. That is a sequela of the intermittent claudication to rest pain, development of ischemic ulcer, or gangrene of the toes. The, the, the symptomatology which limits the body activities or lifestyle activities and non-healing ulcer and rest pain or gangrenous changes occur in the toes. These are the warning signs of critical limb ischemia. That is, the peripheral artery disease symptoms have been divided in two groups. One is the claudication. The second thing is the rest pain. The development of ischemic ulcers or gangrenous changes. These three physical signs that is highly suggestive the patient limb or tissue is threatened. So it is very important that this critical limb ischemia is not checked up or is not properly managed. You can lose the limb that will lead to amputation. The claudication occurs, the symptoms occurs one step below the level of occlusion. If you look at the arterial system of the lower extremities, that is bifurcation of the aorta, common iliac artery, and passes the inguinal ligament, become the common femoral artery. Profunda femoris gets off from the lateral aspects of the profunda of the common femoral artery, which is called profunda femoris, and then after the origin of the profunda femoris, this artery is called superficial femoral artery. It has a proximal part and the distal part in the Hunter's canal or adductor canal covered by sartorius. This is the distal part of the superficial femoral artery, and then when it exits through the Hunter canal, it becomes the popliteal artery, and the popliteal artery undergoes trifurcation, interior, posterior, tibial, and the peroneal arteries. Claudication, that is a symptom, usually occurs one level below the level of occlusion. If you start with if the occlusion is at the level of aortoiliac segment or little above the termination of the aorta into two common iliac arteries, or aortoiliac disease, that is the atheroma extending from the termination of the aorta to the both the common iliac arteries, that's called aortoiliac disease. The patient complains of claudication in this situation in the buttocks. Buttock claudication, of course, the claudication of thigh and the calf do occurs because the lesion is at higher level. So one step below aortic iliac disease develops claudication in the buttocks. If the occlusive lesion is in the external iliac artery, the claudication occurs in the mid-thigh. If the occlusion is the common femoral artery below the inguinal ligament, the claudication will be occur in the calf muscles. That's the calf claudication, which also includes the occlusive lesion in the proximal part of the superficial femoral artery. Aortoiliac, buttock claudication, external iliac, mid-thigh claudication, common femoral artery, or the inclusion of also the superficial or the proximal part of the superficial femoral artery, the claudication is at the calf muscles. If the lesion is present in the distal part of the superficial femoral artery in the adductor canal or the popliteal artery, the claudication not only in the calf muscle but also in the foot. So that shows the pain, dull aching pain which comes on exercise or walking depending upon the level of the obstruction, and the symptomatology develop a one level below the level of the occlusion. So this is very much important to remember because the aortoiliac block buttock claudication. If the lesion is only in the external iliac artery, mid-thigh claudication. If the lesion, obstructive lesion, atheroma or lies in the common femoral and the proximal part of the superficial femoral artery, claudication in the calf. If the lesions involving the fempopliteal segment in the adductor canal or extending to the popliteal artery, then the claudication is in the foot. The intermittent claudication is very diagnostic of vascular occlusion, and the differential point from the spinal claudication that this pain never goes away on rest, while the vascular claudication which comes on walking disappear when you stop walking. The pain which goes away with rest induced by walking is vascular claudication unless otherwise ruled out. The rest pain, because of the vasculogenic in nature, may mimic with diabetic neuropathy, which also causes pain in the foot. But the vasculogenic claudication of the foot, the pain gets relieved by dangling the lower extremity along the side of the bed, because gravity does aid to the flow of the blood in the arterial system, while it is not with the diabetic neuropathy which cause pain, constant pain in the foot. So these are two important points: the foot pain at rest, the most important cause is diabetic neuropathy versus vascular claudication. The only differential point is one, when you tangle the leg along the side of the bed, gravity helps to improve the blood flow to the arterial system, the pain goes away, while the diabetic neuropathy which causes pain in the foot at rest never goes away. The symptomatology is the intermittent claudication, and if it is unchecked, it can lead to critical limb ischemia, that is rest pain without any activities, non-healing wounds or ischemic ulcer on the distal part of the foot, very painful, or gangrene changes or gangrene, and the patient's activities, they are limited to a very limited space. He can't manage or she can't manage herself in the house. The pain is so severe, intractable pain. So that is about the symptomatology of the chronic arterial insufficiency. Regarding the investigations and the treatment. The investigation, which is non-invasive, very helpful to diagnose of the case of chronic arterial insufficiency, is the ankle brachial index. I repeat, the simple non-invasive test which cleans the diagnosis of chronic arterial insufficiency of the lower limb is ankle brachial index. What is that? You record the systolic blood pressure at the ankle and divided by the brachial systolic pressure. The ratio of the ankle divided by brachial pressure, it turns usually in a normal person, it is 0.9 to 1.1%. If the ankle brachial pressure is less than 0.9, that is a warning sign of arterial insufficiency. You can simply demonstrate, you ask the patient to walk for a certain distance. When the patient complained of the pain, you stop it, and at that time you check the ankle brachial index. You will surprise the ankle brachial index falls from 0.9 to 0.6% or 0.5%. That shows the significant lesion in the peripheral arterial system of the lower extremity. So that is a simple, very useful, non-invasive test to diagnose clinically of arterial insufficiency. When you perform this test, at the same time you can check the pulses. You will find the volume, the pulses, they disappear below the level of the occlusion. That further confirms your diagnosis of peripheral arterial insufficiency. Ankle brachial index is false positive in a patient of diabetes mellitus. This ankle brachial index usually is 1.2 or more than 1 in diabetes mellitus because the vessels, they are rigid, calcified and non-compressible. That is why the only drawback of ankle brachial index, which shows a false positive in diabetes mellitus, in which the vessels of the leg, they are incompressible, they are rigid, or they are calcified. So that is one thing you should keep in mind. The ankle brachial index is false positive or normal, you can say, in case of diabetes mellitus or end stage renal disease. The second test, which is non-invasive and helpful to let you know what is the level of blockade. One is the clinical examination. I told you to check the pulses present and the pulses disappear below the level of occlusion. Second thing is you perform a test which is called duplex ultrasound. Duplex ultrasound means Doppler studies of the arterial system of the lower limb, and this duplex ultrasound is a gold standard investigation which is non-invasive and very helpful to let you know the level of the occlusion of the arteries. Is the occlusion is at one level or multiple occlusive lesions? Doppler ultrasound is a very useful gold standard investigation for the diagnosis of chronic arterial occlusion of the lower extremities. So one thing is the ankle brachial index, 0.9 to 1 is normal. When the level is below 0.9, it shows the start of the arterial insufficiency to get to start the claudication. If the ankle brachial index is 0.5, that is the start of rest pain. And if the ankle brachial index is 0.4, It means the patient has developed the ischemic changes in the foot, that is non-healing ulcers. If the ankle brachial index is 0.3, less than 0.3, less than 0.5, less than zero point 0.9, so zero point 0.9 is normal. Start of claudication is less than 0.9. Start of the rest pain, the ankle brachial index is less than 0.5. Development of ischemic ulcer, ankle brachial index is less than 0.4, and the patient develops gangrenous patch in the foot, the ankle brachial index is less than 0.3. So these are the parameters which will let you know the severity of the arterial insufficiency, and that also let you know the critical limb ischemia when the stage of intermittent claudication has gone to a complete obstructions, which leads to continuous pain, rest pain, ischemic ulcer, or the gangrenous patch, and limitation of your indoor activities. Second is the duplex ultrasound, very useful investigation. I repeat again, that will let you the level of the occlusion and the occlusion is only one in the vessel or multiple occlusions. The third investigation, if you want to do something for this chronic arterial insufficiency of the lower extremity, you want to see the whole cardiovascular system, and the investigation choice is the CT angio. The CT angio gives you a lot of information of the arterial system of the whole body. That shows the severity of the atherosclerosis or any narrowing above the level of the bifurcation of the aorta. What about the status of the rest of the vessels? CT angio has to the test of time to look for the chronic peripheral arterial insufficiency of the upper lower extremities on other different viscera. But if you want to plan the surgical treatment, either the endovascular or open, the investigation which has to be tested is of the time is the arteriography. You inject the dye and you get the entire map of the whole arterial system of the lower extremities, and this is what is called as the arteriogram. Is a gold standard investigation when you have decided to do a surgical intervention in a critical limb ischemia. So if you look behind, there are 4 investigations. One is when you suspect a chronic arterial insufficiency of the lower limb, ankle brachial index. I told you normal is 1. Systolic pressure of the ankle divided by the systolic brachial pressure, the ratio is usually 1 or 0.9 is normal. And if the values goes down, that's the various warning signs of critical limb ischemia. Then the investigation is duplex ultrasound. If the patient has a critical limb ischemia, it is very important to know the vascular status of the whole body regarding the atherosclerosis or coronary atherosclerosis. Then answer is the CT angio. That's a very useful investigation. It's the test of time to get the roadmap of the entire arterial system of the body. And if it's specific to do the surgical procedures on the lower extremities or upper extremities, the arteriogram is a gold standard investigations that will localize the segment which is target lesion in the vessel. Regarding the clinical examination of the chronic arterial insufficiency, history is very important. Intermittent claudication, the physical signs, the volume of the pulse is decreased or the pulse is absent on one side just below the level of the collision, or you can say the pulse volume is decreased. So check the femoral pulses, popliteals, tibials, and the dorsal pedis artery. These lesions are, this is a very important physical examination, is the palpate the right from the femoral pulses up to the dorsalis pedis artery, which runs in the first intermetatarsal space. Second thing, you should look clinically the loss of hairs on the dorsal aspect of the foot and the leg. The third thing, you find the skin become very thin and atrophic. Look for any non-healing ulcers on the foot. Majority of the ulcers, they are deep, painful, distal part of the foot. Sometimes it is so deep to involve the infection of the bone also. Then sometimes you will get the obvious wasting of the muscles. So these are the signs of physical signs of chronic arterial insufficiency. Sometimes the patient will have got a rhubarb on rest or wasting, obviously when the collision is very progressive. The treatment of the chronic peripheral arterial insufficiency, I have already told you the underlying pathology is the atherosclerosis, which affect the tunica intima and part of tunica media. The adventitia is spared in the atherosclerosis. That is the layer of the vessel wall which shows the integrity of the vessel and all the vascular operations which done only on the basis of this layer of the wall integrity. For a intermittent claudications, the treatment is conservative or medical. The factors which adversely affect the vascular claudication is, number one is smoking. You must stop smoking at any cost. Smoking is one of the cause of hypercoagulable status or hypercoagulable state. The most important acquired cause is smoking. Nicotine, even in smokeless, is prohibited. Stop smoking, it will prevent the progression of the disease. Second factor which modify the cardiovascular risk is the rehabilitation of the exercise. One should walk unchecked exercise, brisk walking, or should walk to a distance when the patient complains of claudication, and this will help to improve the collateral circulation. So exercise in the form of walking or treadmill, supervised exercise will definitely prolong the claudication distance, and because of the development of collaterals. Collaterals develop because of the abnormal pressure gradients, which allows the budding of the new vessels from the pre-existing vessels, and the This is what is called as postnatal angiogenesis. That's the budding of the new vessel from the pre-existing vessels, and the angiogenin is involved in this postnatal angiogenesis. Angiogenin is a hormone which is involved that results in budding of the vessels from the pre-existing vessel. So one should do the exercise, walking. So till the patient complained of pain. So in this way you can improve the collateral circulation and your claudication distance will be increased. So rehabilitation of the exercise is very important. If the patient has got uncontrolled diabetes, that must be controlled, because the diabetes mellitus, it will aggravate, it will accelerate, it will exacerbate the atherosclerosis. So one must control the diabetes, and HbA1c should be less than 7. If the patient has got a dyslipidemia, increased level of triglycerides, one should use this statin. That is, lovastatin is a drug which prevents the atherosclerosis. Patient must control the blood pressure, and the pressure should be less than 140. The drug which are used for the controlling the blood pressure is AC inhibitors. That is the drug of choice in a patient who has got peripheral arterial insufficiency, is AC inhibitor to control the blood pressure. Or to reduce the cardiovascular incidence or cerebral strokes, you can use the beta blocker also to control the blood pressure. So blood pressure should be less than 140. By using the statin, you can reduce the level of cholesterol below 120 milligram. It prevents the atherosclerosis. The drugs which is used in addition to that is aspirin. Aspirin, it is reduces the stickiness of the platelets, and the aspirin can be used from 75 milligram to 350 milligram per day. Or other antiplatelet agent is the Plavix or clopidogrel. This is also a drug you can use if the patient is sensitive to aspirin. The drugs which can be used to increase the claudication distance, one is the pentoxifylline, is a serotonin antagonist, not available in USA. Pentoxifylline, it will improve the claudication distance, it stabilizes the atheromatous plaque. And the other drug is the phosphodiesterase inhibitor type 5, cilostazol. This drug also increases the claudication distance, prevents the atherosclerosis, and improve the circulations of the extremity. That is cilostazol or pentoxifylline. These are two drugs. One is serotonin antagonist, and that is pentoxifylline, and the phosphodiesterase inhibitor type 5 is the cilostazol. These are the drugs which are used to improve the circulation, to reduce the atherogenicity, to provide the stability to the atheromatous plaque. So all these, and of course the diet should be low in fat and more in protein, and the fruits and vegetables increase the fiber in the diet, also helpful. And you should avoid the sedentary life. The mobility should be more in your lifestyle. These are the measures you can take in case of intermittent claudications. And if you do all these measures, there is a marked increase in the claudication distance. You can manage yourself in the surroundings, and the disease is well controlled by taking all these measures. And these measures also reduce the cardiovascular events and reduce the mortality and the morbidity. The indication of surgery when there is a critical limb ischemia. The indication for surgery, one is critical limb ischemia, which includes rest pain, development of non-healing ischemic ulcers, the development of ischemic changes in the toes, the gangrene. This is what is called critical limb ischemia. If you will not treat at this moment, you are going to lose the limb. Second indication is the patient lifestyle is limited to a certain distance. He can't or she can't manage herself or himself in the house. It's difficult for her or him to go to the toilet. So the pain is so severe. So lifestyle is totally changed. Or if there is a arthromatous embolization. So critical limb ischemia, lifestyle change, and the embolic process because of arthromatous embolus, which can go distally and cause the occlusion of the digital arteries. But these are the warning signs that you can lose the limb if you will not operate on these patients. So there are two types of operations. One is the open operations. I am going to tell you the basic principle, what sort of operation you will do when the patient has critical limb ischemia or the pain is so severe that cannot manage herself or himself in the house, or arthromatous embolization, the arthromatous plaque broken and goes distally to involve the digital arteries blockage, leads to gangrene. There are two types of the treatment, open or endovascular. When I say endovascular, you treat the target vessel within the artery from inside. You select the healthy vessel, do the arterotomy, and pass the sheath and the guide wire and use the balloon catheter. So endovascular is evolving, and it is one of the more wanted treatment for in the peripheral vascular disease. That is endovascular repair or endovascular therapy, which includes transluminal angioplasty. That is, you pass the guide wire over it, you put a catheter and you inflate the balloon at the site of the lesion. It will crack the tunica intima, compress the tunica media, and stretch the tunica adventitia. The arthromatous plaque will push out, and then you can later on aspirate, and that is what is called angioplasty. To maintain the caliber, sometimes you may add with the stents. So the endovascular treatment consists of the target lesion should be addressed from within by doing the transluminal angioplasty, with or without stents. Stents, they can be used, simple stents or covered stents, which are covered with the uh, sort of a fabric coating. This is what is called as the endovascular repair. Transluminal angioplasty with or without stent. Very useful treatment for short stenotic lesion. If the stenotic lesion is less than 2 centimeter, this is an ideal treatment to deal with target vessels by doing the endovascular revascularization, and that is called PTA, percutaneous transluminal angioplasty, and sometimes you have to put a stent. It is a depending upon the situation, or is custom made with or without angioplasty. Angioplasty means you dilate the stricture, you crack the atheroma, pushed out, stretch the media and adventitia, the caliber is attained, and if you think that is going to be clogged, you can add up with the stent. The second treatment is the open operations. Open operation means bypass operations. That is, you have to bypass the diseased vessels, and the operation means there are various types of bypass. First, if the disease is aortoiliac, that is, the atheroma is the terminal portion of the aorta, which is extending to both the common iliac arteries. The treatment of choice is you take a graft, which graft is called Teflon graft, and that is called aortobifemoral bypass graft. The graft is like a trouser. The upper limb, the trunk is attached to the aorta above the level of the lesion, and the two limbs, they are attached to the common femoral artery below the inguinal ligament. That is called aortobifemoral pass. When the patient has got a aortoiliac disease, aortobilateral iliac disease, when you do this aortobifemoral bypass graft, which is made of Dacron or Teflon, one should be very important to know there should be some back bleeding from the internal iliac artery or hypogastric artery. If there is no back bleeding, the perfusion is low, the patient is likely to develop the impotence. So that is why it is important, if there is no backflow from the hypogastric artery or internal artery, you have to bypass the internal iliac artery also with the graft. One thing is Larynx syndrome. It is characterized by, one is impotence. The basic line is the terminal portion of the aorta or aortoiliac segment, and there are no femoral pulses, and the patient complained of buttock claudication, bilateral. This is what is called as the Larynx syndromes. Larynx males, aortoiliac disease, bilateral, and the impotence. The femoral pulse is absent. Patient has got a buttock claudication. There is a pain in the buttocks. The treatment in a good fit patient is the aortobifemoral bypass graft. So the flow can be established in both the lower extremities, and if the flow is one of the two hypogastric arteries there, that is enough to prevent the impotence. Otherwise, the patient will develop vasculogenic impotence. You have to bypass the one of the hypogastric artery to provide the flow to the pelvic viscera. If the disease is localized to one aortoiliac, the segment is short, stenotic, you can get the treatment with the endovascular. You do the arterotomy and you pass the angioplastic catheter and do the balloon dilatations with or without stent. That will improve the flow in unilateral disease involving the aorto-like segment. But if the disease is extensive, then of course you can take the help of aortofemoral bypass. If the patient is unfit, having a bilateral aortic iliac disease, endovascular is the first thing to pass. You dilate the aortoiliac segment and put a stent there, and similarly on the other side, you explore the femoral artery and you pass the percutaneous transluminal angioplasty and then put a stent there. But there are higher chances of closure within 5 years. They require a lot of follow-up, and because you may need a re-intervention in a poor risk patients. But if the patient is a good risk for a bilateral aortic iliac disease, the best option is aortobifemoral bypass graft. Regarding the fempopliteal segment, which starts below the inguinal ligament to the origin of the tibial artery, this segment is also very notorious for atherosclerotic occlusion. The common site of the occlusion is the superficial femoral artery in the adductor canal, where this artery exists out to become the popliteal artery. The best treatment for this one, fempopliteal segment disease, is fempopliteal bypass. For the fempopliteal bypass, is very important that the inflow, the outflow, and the conduit is good enough. Inflow, that is where you do the anastomosis proximally, there should be healthy artery, and where you fix up the anastomosis distally with this conduit should also be healthy. And the conduit, that is a graft, the best graft for the, in this situation, for fempopliteal disease, where you do the fempopliteal bypass, is the reversed great saphenous vein that has got the highest patency rate as compared to the graft, other graft, the synthetic grafts. Synthetic grafts, they are good above the level of the knee joint, but below the level of knee joint, the vein graft is the best because it has the highest patency rate as compared to synthetic graft. Synthetic grafts, which includes PTF, for the femoral artery above the level of the knee joint. Below the level of knee joint, vein is the best. Above the level of the knee joint is the synthetic graft P polytetra fluoroethylene, PTFE, that is called Gore-Tex. And the third graft is the Dacron graft, which is used for the aorta and the major vessels. So the best is the autogenous or autologous vein graft. Second is the PTF, and third one graft is called Gore-Tex. So you can have a Gore-Tex, Dacron, and the autologous vein graft. So one is the vein graft, ideal if you want to do the anastomosis below the level of the knee joint. Then the PTF, this is called as the Gore-Tex graft, that is for the above the level of the knee joint. If you want to bypass the vessels, you can use this Gore-Tex or Teflon graft. And if you bypass grafting for the aorta and major vessel, then it's called Dacron. So Dacron, Teflon, or autogenous or autologous saphenous vein graft, There are three types of graft. One is the autologous saphenous vein graft, very ideal, high rate of patency. Second, synthetic grafts are the Teflon or Dacron or graft. So Dacron for the aorta, Teflon or Gotus graft for the vessels to bypass above the level of knee joint and below the level of knee joint from fempopliteal bypass the reverse autologous saphenous vein graft. So there are three grafts. The patency is very good for the autologous vein graft. Vein quality is the predictor of patency versus the synthetic graft. So these grafts they can be used to bypass the major vessels, and the lower graft below the level of the knee joint, the patency rate is very poor, especially for the synthetic graft. And in this case, you can use the femoral artery and then you join distally to the healthy part of the peroneal or the tibial arteries for the severe ischemia of the foot. So fem tibial or peroneal graft or low bypass graft have a poor and they have a high failure rate because they gets blocked quickly if there is no distal runoff below the level of the ankle joint. That is very important. For the low bypass grafting, the distal runoff below the level of the ankle should be good runoff. So that is about the open surgery bypass grafting. And the other open surgery, sometimes the lesion is very short, you can do the what is called endarterectomy with patch angioplasty. You open the artery, remove the atheroma, and close with the patch of the vein. That is called endarterectomy of a stenotic lesion, which can be approached directly on the target vessel by making an incision and remove the atheroma and close the vessel with the patch of the vein graft. It's called patch angioplasty preceded by endarterectomy. That is another open operation for stenotic short lesions if the endovascular repair is not available. And the last one is the amputations. If the gangrene has developed, there is no other chance that you have to amputate it. So amputation, endarterectomy, and the bypass grafting, these are the options depending upon the situation or condition of the patient, and they are custom made. Endovascular treatment is PTA, percutaneous transluminal angioplasty of the disease segment, may and may not with the stent. That is all about the medical treatment and the surgical treatment of coronary arterial insufficiency of the lower extremity. The patency rate is good above the level of the knee, and the patency rate of the graft is poor below the level of the knee because of the poor collaterals distal to the anastomosis. That is all about the chronic arterial insufficiency of the lower extremities.